السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله. Welcome to our radiology course, lecture 7. I am Dr. Nihad. On today's session, abnormal calcification of the abdominal X-ray. Understanding these calcifications is crucial for accurate diagnosis and patient management. Throughout this lecture, we will explore the different types of calcifications, their clinical significance, and how to differentiate them on imaging. Let's dive in and enhance our understanding of this important topic. Starting with key points. Knowledge of the X-ray appearances of abnormal abdominal calcification is necessary to avoid confusion. Other imaging investigations are often more informative for assessing abdominal calcification. First, we will start with renal calcifications. Renal calcifications can affect the renal collecting system, calculi or the synonym, the stones, or the kidney parenchyma, nephrocalcinosis. Other investigations, renal calculi may be visible on the control study of an IVU, which is intravenous urogram, which is done by injecting contrast material IV, and then we take a later image for the kidneys and ureters and bladder. Renal calculi may also be visible with ultrasound or CT of the kidneys, ureter, and bladder, which is CT-KUB. Renal calcification. Abnormal renal calcification may affect either the renal parenchyma, then we call it nephrocalcinosis, and nephrocalcinosis have two types according to the anatomical position where this parenchymal calcification is stated. Either cortical nephrocalcinosis or medullary nephrocalcinosis. Then again, abnormal renal calcification may affect either the renal parenchyma, then we call it nephrocalcinosis, or more commonly the collecting system, then it's called renal calculi. Pelvic calyceal calcification, renal stones or calculi are concentrations of inorganic material within the renal collecting system. 90% of renal calculi contain enough calcium to be visible on abdominal X-rays, and some are not visible, like urate and matrix, protein matrix type of stone, which are not visible. Renal stones are often small, but if large, can fill the renal pelvis or a calyx, taken on its shape, which is likened to a staghorn. For example, here we have a single type of renal stones which called staghorn calculus. In this image, this is the staghorn calculus. The irregularly shaped calcific density has filled and taken on the form of the right kidney lower bole calyx. This is staghorn calculus within the renal pelvis. Again, the annotation within the image, this is the right kidney, staghorn calculus, which fill the renal pelvis. In cases of nephrocalcinosis, uncommonly the renal parenchyma can become calcified. This is known as nephrocalcinosis, a condition found in disease entities such as hyperparathyroidism, one of the metabolic disorders causing calcium deposition within the kidney, medullary sponge kidney, which is another type of abnormalities. Nephrocalcinosis, like in this image, we can see cortical type of nephrocalcinosis. Here we have right kidney with calcification, which is collected in the cortex. This is nephrocalcinosis because it is collection not in the pelvic or the collecting system, but it is within the parenchyma itself, and specifically the cortex. The renal parenchyma contain cluster of small calcific densities, here in a plain radiograph, and here with this pink marks. Moving to the next type of calcification, ureteric calcifications. The key points: if clinically suspected, look very carefully for a ureteric stone. Other investigations, IVU or CTKUB, can be used to determine the position of a stone and the degree of obstruction, because some types of stones doesn't appear in X-rays. If these are contraindicated, then ultrasound can be used to determine the presence of renal outflow tract obstruction. In ureteric calcification, ureteric stones are often seen on an abdominal X-ray performed as a control study for an IVU, because in IVU we start with a plain X-ray radiograph before starting the procedure. This control image is known as kidney ureter bladder KUB image. As with renal stones, approximately 90% are visible. Ureteric stones originate as renal stones. If a renal stone migrates into the ureter, it may cause renal outflow tract obstruction, which manifests clinically with severe ipsilateral flank or lying groin pain, usually with hematuria, because when the ureteric stone descends, it can cause injury within the layer covering the ureters. And flank and lying pain, most probably due to the urinary outlet obstruction and causing hydronephrosis within the same side of the ureter. Hydronephrosis, which means collection of fluid within the renal pelvis and distended renal pelvis. And this condition should be treated so as to do not lead for renal failure. In this image, we have downward in the mid-ureter a stone adjacent to the iliac bone between it and the vertebra. In this place, here a ureteric stone. This is transverse process of the vertebra, the lumbar vertebra, and here we have the ureteric calculus downward. Ureteric stone or calculus, look carefully for ureteric stones, which can be very subtle. Don't mistake a transverse process for a stone. This is the rule. Now moving to the next type of calcifications. The bladder stones. Key points for bladder stones: form in the bladder as a result of urinary stasis. Other investigations, although ultrasound only occasionally show renal or ureteric stones, it is a much more reliable examination for bladder stone. In ultrasound, bladder stones generally form in the bladder itself. They arise as a result of urinary stasis, such as in bladder outflow obstruction, in cases, for example, of enlarged prostate, like in benign prostatic hyperplasia, or in patients with a neurogenic bladder, loss of bladder function due to spinal cord injury or disease, and which lead to cutting the nerve supply of the bladder, leading to neurogenic bladder. Those with bladder wall abnormalities also, like ureteroceles, which cystic dilatation of the ureter, and diverticulum, which outpouching of the bladder wall, which can lead to stasis within it and formation of stones, or those with recurrent urinary infections like elderly patients are also at higher risk to form bladder stones. When seen on an abdominal pelvic X-ray, they are often multiple and rounded. Bladder stones, multiple well-defined calcific densities, are seen within the bladder. Like in this radiograph, we can see multiple pelvic calcifications and large. Here we have bladder stones within the bladder in the pelvic radiograph. Now moving to the next. Vascular calcification. Key point, don't forget non-GIT causes of abdominal pain. Other investigations, an abdominal aortic aneurysm can often be seen with ultrasound, but is more definitely assessed prior to treatment with CT. Vascular calcification of arteries seen on X-rays is a sign of more generalized atherosclerosis. Occasionally, vascular calcification seen on an abdominal X-ray reveal an unexpected aneurysm. Remember that abdominal pain is not only caused by GIT diseases. Sometimes it can be due to vascular abnormalities like rupture abdominal aortic aneurysm. In this image, we can see the calcification within the abdominal aorta and its branches without aneurysmal dilatation. Vascular calcifications, there is a striking calcification of the aorta and iliac vessels. This is a sign of generalized atherosclerosis elsewhere in the body. This the calcification within the aorta, extending to the femoral vessels. Now moving to the next. Here, calcification in an abdominal aortic aneurysm. Abdominal aortic aneurysm, there is calcification of the dilated aortic wall. Frequently, only one side of the aneurysm is visible, as in this image, the other being projected over the spine, so we can't visualize it. Here, the calcification within the abdominal aortic aneurysm wall. Over here, again and again. This is abdominal aortic aneurysm calcified wall. When the abdominal aortic aneurysm is calcified, its tendency to rupture is less because of calcification means that it's chronic and old within the wall. But if no calcification, then the rupture may be pending. Moving to the next type of calcification, retroperitoneal calcifications. When we say retroperitoneal calcification, we mean calcification within the organs that retroperitoneal in location. The key points: pancreatic calcification is a sign of chronic pancreatitis. Adrenal calcifications is usually an incidental finding. Other investigations, retroperitoneal calcification can also be seen incidentally with CT. Occasionally, you may see calcification of retroperitoneal organs such as the pancreas or adrenals, which only become visible when calcified. Pancreatic calcification is a feature of chronic pancreatitis. Adrenal suprarenal glands calcification is an uncommon finding and is usually incidental. Most often, it is considered a result of previous hemorrhage or tuberculosis. Here we have an image with pancreatic calcification, drawing the shape of the pancreas. Chronic pancreatitis, this X-ray shows soft tissue calcification which follow the anatomical position of the pancreas. Also note calcification of the abdominal aorta, which is of normal caliber. Again, here the abdominal aorta with calcification, and this is with drawing the lines. Here the calcification within the pancreas and aorta. Moving to the next, adrenal calcification. Adrenal calcification, the adrenal or suprarenal glands form a triangular shape or triangle shape lying directly above the kidneys. Over here we can see on either side of the spine there is triangular shape of calcification drawing the adrenal shape. Here we have right adrenal gland, left adrenal gland with the adjacent kidney in each side. So this is adrenal calcification with apparent renal shadows underneath. Moving to other type of calcifications. Viscous calcification. Key points: the gallbladder and hence gallstones have a variable position. Most gallstones are asymptomatic. Appendicolith is an occasional but important X-ray feature of appendicitis. Other investigations: ultrasound is the initial investigation of choice for suspected gallstones. Ultrasound or CT can be used to investigate appendicitis, but the diagnosis is usually made clinically. Viscous calcification. Abnormal calcification also occur in the hepatobiliary tree and the gastrointestinal tract, such as appendix, as appendicolith. So when we speak about viscous calcification, that means the type of calcification occur in viscous organs, which mean hollow organs. Gallstones are very common. Approximate 20% of the adult population in Western countries have gallstones. They can become pathological if they fall out of the gallbladder into the biliary tree. Only 10 to 15% of gallstones contain enough calcium to be visible on an abdominal X-ray. If they are visible, don't assume they are the cause of abdominal pain, as most are asymptomatic. Gallstones and mesenteric lymph nodes in this image. Gallstones and mesenteric lymph nodes. Gallstones have a variable position depending on the position of the gallbladder and may be mistaken for renal stone because they are right and below the liver, adjacent to the renal place. Unlike renal stones, they are often rounded and clustered together. This X-ray shows an incidental calcified mesenteric node, which may also mimic renal stones. Here we have the calcified gallstones, and in other side calcified mesenteric lymph node. At the beginning, it can mimic renal stones bilaterally, but confirmed with CT that they are calcified gallstones and mesenteric lymph nodes. So it is so important to correlate clinically, and if you are not sure, to go further after X-ray and ultrasound for CT if there is no contraindications. Moving to appendicolith. In appendicitis, which is the inflammation of the appendix, the abdominal X-ray is usually normal and is not a required investigation unless a complication such as perforation is suspected. Occasionally, an appendicolith is seen. This is a small calcified stone within the appendix and is seen in the right iliac fossa. Although an uncommon feature of appendicitis, an appendicolith is highly predictive of the diagnosis in patients presenting with abdominal pain and also thought to be associated with higher risk of gangrene or perforation if there is appendicolith. Here we have a single calcification which is overlying the right iliac bone in the right iliac fossa. This is appendicolith. Appendicolith are highly predictive of appendicitis in patients presenting with right iliac fossa pain. This is appendicolith. As in this image. Moving to the next type of calcification, which can be due to artifact or foreign body. Key points here: when presenting your findings of an abdominal X-ray, note the presence of artifact, internal or external, because if it can be misunderstood or mistaken for a foreign body. Artifact can be due to medical devices or due to abnormally internalized objects. This page demonstrates a selection of the many medical artifacts you may come across, or objects that are ingested by patient, starting with NG tube, nasogastric tube, nasojejunal tube. Nasojejunal tube placed for the purpose of enteral feeding. The tube passes through the stomach and forms a C shape as it navigates the four parts of the duodenum from D1 to D4. The tube tip lies beyond the duodenal flexure, which lies on the left. So this is nasoduodenal tube. Sometimes it can be mistaken for as it is outside. Here we have a double J stent. Before moving to double J stent, let's see the annotations in the nasoduodenal tube. Over here, coming through the esophagus, stomach, duodenum, part 1 to 4, D4 and D3, reaching the duodenum after cutting the four part of the duodenum, which is type of feeding tubes like nasogastric tube. In nasogastric tube, it's tip end within the body of the stomach or antrum. The next, big tail double J stent, which is used in kidney through ureter to the bladder. This is double big tail stent extending from the renal pelvis through ureter and bladder. A ureteric stent has been placed to relieve ureteric obstruction. The catheter has lobes, big tails, at both ends which hold it in place. This is the double J stent. Tube. Colonic stent looks like a mesh. This is a colonic stent. Colonic stent, large bowel obstruction can be treated with placement of metallic colonic stent. This is often used as a temporary measure, allowing a patient to recover from the effect of obstruction prior to definitive colonic resection. We put it for a while and then remove it with surgery. This is the colonic stent. Inferior vena cava filter, IVC filter. An IVC filter is used to reduce the risk of a large pulmonary embolism, most commonly used in patients who have had pulmonary embolism but for whom anticoagulation is contraindicated. IVC filters are self-expanding wire structures shaped like an umbrella. Small clots may pass between the wires of the filter, but large clots are prevented from reaching the pulmonary arteries. Over here, this is the IVC filter within the inferior vena cava with its tributaries, the iliac veins in blue color. This is the IVC filter. Also type of instruments used to prevent pulmonary embolism. Foreign body ingestion. In this patient, there are multiple types of foreign bodies. Foreign body ingested. This psychiatric patient has ingested numerous radio-opaque objects. The naval jewelry is external, but the other are internal. Nails and screws, glass, batteries, and other pieces of glass. Now we came to the end. Knowledge of the X-ray appearance of abnormal abdominal calcifications is necessary to avoid confusion with other imaging. Investigations are often more informative for assessing abdominal calcifications. Moving to the next, which is the abnormalities of soft tissues and bones. The key points: bone and soft tissues. Bone and soft tissue disease are encountered incidentally on abdominal X-ray. Awareness of the abnormalities you may encounter helps avoid confusion. Ultrasound or dedicated X-rays are required for initial investigation of suspected abdominal soft tissue or bone disease. Soft tissue and bones. Introduction to the bones and soft tissues of abdomen are primarily imaged by means other than abdominal X-rays. Because X-ray is better to image the calcifications and bones, ultrasound is usually the initial investigation for suspected soft tissue abnormalities of the abdomen. Dedicated X-rays are usually required to investigate suspected bone and joint disease. Occasionally, you will come across an unexpected abnormality of bone or soft tissue with an abdominal X-ray. This tutorial briefly discusses a range of these abnormalities. Starting from above, lung bases. There is often a good view of lung bases on a good quality abdominal X-ray. Occasionally, patients with chest disease present with abdominal pain, particularly if the lung bases are involved. Starting with check for pathology of the lung bases. Here in this image, we have pleural effusion within the left side of the chest. Lung bases. This patient had pseudo-obstruction, not the dilated bowel and colon, secondary to a left basal pneumonia. The image shows consolidation and allocated pleural effusion at the end of lung base. This is the pleural effusion with the density of a soft tissue density and dilated colon. Now moving to the next. Solid organs. Although ultrasound and CT are more informative means of imaging the solid organs of the abdomen, occasionally you will see evidence of enlarged organs on an abdominal X-ray. Here we have hepatosplenomegaly. There is diffuse soft tissue density shadowing in the right upper quadrant due to hepatomegaly. Liver enlargement. The enlarged liver has displayed the normal bowel downward, and to the left arrows, the spleen is also mildly enlarged. And these bowel segments are displaced more centrally and downward. The key points here: if enlarged, the solid organ of the abdomen may displace bowel. As in this image, spleen is mildly enlarged. Sometimes it can be massive splenomegaly, like in this image. Massive splenomegaly, this patient with myeloproliferative disorder has both hepatomegaly and massive splenomegaly. There is a generalized increase in soft tissue density, but the bowel appear pushed away by the edge of the spleen because it comes obliquely toward the center from the left upper quadrant toward the right lower quadrant. Then we have enlarged kidneys, like in this image. We have enlarged normal shadow of the kidneys, right and left, bilateral. Both kidneys are very enlarged. The bowel is not displaced because the kidneys are retroperitoneal structures. So in liver and spleen, hepatomegaly and splenomegaly enlargement, there is also bowel displacement. But here in the kidney enlargement, it doesn't affect the position of bowel because they are retroperitoneal. Again, both kidneys are very enlarged. The bowel is not displaced because the kidneys are retroperitoneal structures. This patient had a family history of polycystic kidney disease. This diagnosis was confirmed by ultrasound. This is the image without annotations, and this is with annotations. Here the image of the massive splenomegaly, and here without. Now moving to the next, ascites. Abdominal X-rays shouldn't be used to check for ascites. The key points: free fluid and solid organs have similar densities. In the presence of ascites, gas within bowel is located centrally. Ascites, again, if this diagnosis is suspected, then again ultrasound is the best initial investigation and can also be used to assist drainage. So we have some type of drainage called paracentesis to drain an abdominal massive ascites, and paracentesis now is done with ultrasound guidance. Fluid and soft tissue have similar densities, and so ascites may be mistaken for organomegaly. The bowel doesn't appear pushed on the side as on organomegaly, but rather gas-filled bowel rises in a central position in the supine patient. Here an image with ascites. It looks like the previous case of massive hepatomegaly, splenomegaly. Ascites, there is generalized hazy density of the entire abdomen. A loop of gas-filled bowel lies centrally in the abdomen because it is floating within this fluid outside the bowel. Here, the ascites filling the abdomen. It looks like the football sign of the pneumoperitoneum in the last session, but the difference that the air is loosened, but here the water is slightly more brighter than that. Moving abdominal and pelvic masses. Key points here: pelvic masses can displace bowel upward. This is a hint. Occasionally, masses of the pelvic or pelvis are visible on an abdominal X-ray. If large masses of the pelvis may extend into the abdomen and displace bowel according to its size. Investigations with ultrasound and or CT is required for assessment of suspected abdominal masses. Over here we have a pelvic mass, large pelvic mass. The annotations which displace the bowel upward. Here we have this whitish of soft tissue density, the pelvic mass. A very large soft tissue density mass extends upward from the pelvis. Bowel is displaced superiorly in the abdomen. Here we have a small pelvic mass, which may be difficult to visualize in the X-ray. A right pelvic wall mass is easily missed. If you see a mass on an abdominal X-ray, re-examine the patient before planning further imaging, because further imaging can need a certain protocols like CT with a certain protocol according to the suspected abnormality. So discuss this with the radiologist you are referring your patient to. Now moving to the next. Sometimes we can use abdominal X-rays to assess fractures and osteoarthritis. The key points here: abdominal pain or tenderness may be caused by bone or joint disease. Fractures and osteoarthritis. It is not uncommon for patients with bone disease to present complaining of abdominal pain. Doctors often ascribe abdominal symptoms to GIT disorders without considering other causes. Tenderness on palpation of the abdomen may be due to radiated bone pain. If you suspect bone disease, then request dedicated X-rays of the bone or joint in question rather than an abdominal X-ray. Here we have a pelvic fracture with osteoarthritic changes in an elderly patient who have a hip prosthesis. Pelvic fracture and osteoarthritis. This elderly patient present with abdominal pain with no clear history of trauma. Tenderness in the suprapubic regions was thought to be due to intra-abdominal pathology. The pubic ramus fracture was the cause of symptoms, not the osteoarthritis or arthritic chains. Osteoarthritic chains. Appearance of the hip and lumbar spine. And in elderly patient who has osteoporosis, they are prone to fracture from minor trauma. You have to consider this. Moving to the next. Rest of bone diseases also can be considered while you are imaging your patient with an abdominal X-ray. Assess bone and joints on an abdominal X-ray. Bone disease may be incidental or pivotal to diagnosis. Localized or widespread bone disease may give rise to abdominal symptoms. If you suspect bone or joint disease, then dedicated images of the area in question are required. Occasionally, there will be unexpected bone disease seen on an abdominal X-ray, which may be incidental only. Incidental means the type of findings that you didn't mean to image your patient accordingly. It's just an incidental finding by chance. Or pivotal to diagnosis. Pivotal to diagnosis. Bone tumors, bone metastasis may be seen on abdominal X-rays. These can be lytic, low density, black, or sclerotic, higher density, white, according to the origin or its type. Some bone metastasis or other organ, when it is metastasized to the bone, it have lytic nature or sclerotic nature, according to its effect, either destruction or slow in progression. The destructive one appear as lytic, and the slower in growing appear as sclerotic. For example, breast cancer mets appear lytic, and prostatic cancer appear sclerotic. The most frequently encountered bone mets are prostate cancer in men, which is sclerotic, and breast cancer in women, which can be sclerotic or lytic, but 90% of breast cancer mets is lytic. Bone metastasis. There are numerous sclerotic densities wide of the vertebra, within the vertebral bodies, sacrum, pelvis, and proximal femora. This patient had a known history of breast cancer, abdominal pain was acutely due to high serum calcium. All over these bones with metastatic breast cancer. Benign bone lesions, like in Paget disease, benign lesions of bone may also be seen incidentally on an abdominal X-ray. Paget disease, this patient has Paget disease, which affect his lumbar spine and right hemipelvis. Paget disease is one of the disorders, metabolic disorders, that have some active and inactive sclerotic and lytic appearances according to phase of Paget disease. Again, this patient has Paget disease, which affect his lumbar spine and right hemipelvis. This was an incidental finding when looking for a cause of abdominal pain. The typical feature of Paget are bone expansion and coarsening of the trabecular button involve the whole of bones affected. This is Paget disease. By this, we came to the end of today's lecture. In summary, for today, bone and soft tissue disease are encountered incidentally on abdominal X-rays. Awareness of the abnormalities you may encounter help avoid confusion. Ultrasound or dedicated X-ray are required for initial investigation of suspected abdominal soft tissue or bone disease, either calcification or any suspected underlying pathology. That is all for today. Thank you and good luck.